All right. Good morning and good afternoon, depending on where you're joining us from, and welcome to today's webinar. My name is Mike Weekly. I am VP of Marketing here at E4 Health. We're glad that you could join us today, especially during this busy holiday season. You can see I'm feeling very festive, but I'm ready to hit the holidays like I'm sure a lot of you are. So appreciate you taking the time. It's a very busy time of year, a lot going on, but we have a lot of great stuff to get to here. Great session lined up today. Our goal is to make sure you leave with the insights and practical guidance you need to confidently prepare for the 2026 CPT code changes. Before we get started, a few quick housekeeping items. The slides will not be shared following today's presentation. However, you will receive a link to the recording in your email, and we will also be posting that in the IQ Education Center within a few days. So you can share that recording link as well. And one other item, you'll get an evaluation at the end of this webinar. I will put that link in the chat and also in the Q&A. Once you fill out that evaluation, you will get your ACDIS and AHEMA CEU certificates. So make sure you stick around for that toward the end. With that, I'm very pleased to turn things over to resident expert Julie Seaman. She's the Vice President of Solution Design here at E4 Health. Julie will walk us through this first wave of CPT 2026 changes, what's new, what's changing, and how to prepare your team for smooth transition. Julie, welcome.
Thanks, Mike. Welcome, everyone, and thanks for joining today's session in the 2026 CPT code update. This year represents one of the most transformative CPT updates we've seen in quite some time, not just because of the number of changes, but because of what those changes represent. CPT 2026 represents how healthcare is actually being delivered today. Digital health, remote monitoring, AI-assisted diagnostics, and complex technology-driven procedures are no longer emerging concepts. They're part of our routine healthcare. Throughout today's session, I'll be intentionally calling out what those changes mean for coders, providers, and your compliance team. This update cannot be implemented successfully in silos. It requires cross-functional alignment to protect revenue, reduce risk, and support compliant care delivery. The scope of change in 2026 is significant. There's 418 total code changes, which includes 288 new codes, 84 deleted, and 46 revisions. Even organizations that believe they only use a narrow subset of CPT codes will feel the impact. These changes affect documentation expectations, bundling logic, supervision requirements, and payer interpretations. So for coders familiar with workflows, they're suddenly going to produce some different coding outcomes. For providers, documentation will be increasingly specific, and they'll be the deciding factor in code selection even more than in the past. And for compliance teams, the volume of changes increases audit exposure and expects increased education and internal controls to keep pace. The AMA has several clear goals with the 2026 updates. First, eliminate outdated terminology and obsolete technology. Second, realign code families with how care is actually delivered today. Third, improve granularity for high utilization services. And finally, formally recognize AI enabled diagnostics and digital health workflows. What does this mean from an operation standpoint? This means that legacy documentation habits may no longer support the services that are being coded, and coders can't rely on historical logic alone. Providers may unknowingly document in ways that no longer align with CPT descriptors, and compliance teams should anticipate some discrepancy where old habits collide with modern expectations. So let's get right into our changes. Remote physiologic monitoring, or RPM, and remote therapeutic monitoring, or RTM, continue to evolve as hybrid care models expand. CPT 2026 refines these services to better reflect real-world practice, but with clearer and stricter expectations. Coders must validate monitoring duration, transmitted data, and time thresholds. And providers must ensure workflows support those requirements because missing documentation directly impacts reimbursement. And from a compliance standpoint, RPM and RTM remain among the most frequently audited services across payers. And that will not be changing in 2026. So here are some of our key changes. One of the most impactful RPM changes in 2026 is the introduction of new treatment management codes for 10 to 19 minutes of cumulative monthly time. Historically, the RPM programs were delivering 12, 15, or 18 minutes of meaningful clinical support, and none of that was reimbursable. This change finally closes the gap. Just like RPM and RTM codes now specify, they require monitoring occur at least 2 days within each 30-day period in order to build device supply codes. A single day of monitoring is no longer sufficient. Coders must confirm multi-day data transmission before selecting a code, and providers must ensure that therapeutic data is actually captured on more than one day. RPM and RTM billing clarifications. It's important to clarify that the 2-day requirement applies to transmitted data, not simply device availability. The days do not have to be consecutive, but they must be clearly documented that 2 days were monitored for that patient, and that the data was actually transmitted. So again, coders must validate the data transmission dates, and we must make sure that the documentation is clear. Taken together, the RPM and RTM changes bring much needed clarity, but they also increase accountability. So coding teams should expect increased QA activity, and providers will need focused education on documentation standards. This puts the compliance team to anticipate that payer interpretations will continue to evolve through 2026. So again, just because CPT is making these changes, we don't know what our payers are going to look like, and we want to make sure that we're on top of that and paying attention to all those changes as well. So telehealth expansion. Telehealth is no longer a standalone service category. It is embedded across RPM, RTM, hybrid visits, and AI-assisted diagnostics. So coders will now encounter telehealth logic throughout the CPT code set. It is no longer a separate set of codes. Providers must document visit modality and supervision method with precision. Compliance teams need to remember that telehealth remains a high-risk enforcement area despite expanded allowances. So just because CPT has expanded it does not mean that your payers are going to continue to expand that. CMS has also made telehealth policy updates, and they are simplifying how services are added to the Medicare telehealth services list and allowing virtual direct supervision for many services. However, this flexibility does come with conditions. Coders must ensure documentation supports virtual supervision. Providers must understand when virtual supervision is permitted, and compliance teams must ensure that global surgical services are excluded from virtual supervision billing. AI-assisted coding growth. In 2026, the CPT code set reflects a major shift toward algorithm-assisted diagnostics, AI-enabled imaging, and software-driven clinical risk assessment. Across cardiology, radiology, neurology, pulmonology, and systemic disease evaluation, the AMA expanded CPT to formally recognize AI-driven analytics as billable medical services. The key takeaway on this is that AI-enabled diagnostics are no longer emerging. They're actually becoming embedded in the mainstream care. Organizations must prepare early by updating workflows, educating their coders, and validating documentation to make sure that they're best positioned to leverage these new capabilities. Cardiology AI codes. So new cardiology AI codes recognize non-invasive cardiac risk assessment, coronary plaque analysis. The movement of some of these codes into Category 1 signals a broader payer recognition and, of course, will create increased scrutiny. Coders must distinguish AI-assisted analysis from traditional diagnostics, and providers need to document this clearly. AI-derived findings and clinical interpretations must be documented and clearly called out. Any compliance teams, the compliance team should ensure that FDA-cleared software aligns with the services being billed. Neurology systemic AI codes, neurology and systemic risk assessment are clearly embraced in CPT 2026 through algorithmic ECG analysis, biomarker testing, and neurodegenerative diagnostics. Coders must select the appropriate code category, and providers should avoid vague references to AI analysis without specifics. AI diagnostic imaging. So AI enhanced imaging continues to expand, including interstitial lung disease classification, prostate estimation mapping, and coronary plaque analysis. These two tools allow algorithms to extract features that cannot be measured visually. They improve diagnostic accuracy and can reduce variability among providers and among testing. The AMA responded by adding new Category 3 codes and refining Category 1 descriptors. Again, we're looking for documentation that supports this new diagnostic imaging. So providers must reference AI-based analysis in reports, and the compliance teams must ensure that AI augments, not replaces, physician interpretation. There still needs to be clear documentation of the physician's interpretation within the report. Interstitial lung disease. New ILD codes describe AI-enabled CT analysis for disease classification, including pattern recognition and fibrotic scoring. These tools provide radiologists with standardized outputs while radiologist remains responsible for the final interpretation. Once again, we want to make sure that there's clear documentation of the provider's interpretation, not just the AI interpretation. We have to have separated documentation to include both the AI analysis as well as those providers' final decisions made on that case. Prostate estimation mapping. So this code supports AI-enabled prostate volume estimation using CT or MRI data sets. Clinically, it saves radiologists time, improve accuracy for treatment planning, and standardizes measurements. Again, we want to make sure that the imaging modality and segmentation requirements are verified by the coders and that the providers document how much volumetric data supported care has been provided. Compliance teams should ensure medical necessity is clearly documented. So again, nothing changes there. We still need to make sure that our documentation is clear. However, having these tools helps to improve outcomes for patients. AI-based coronary plaque analysis. This AI-based coronary plaque analysis code is notable because it's achieved Category 1 status, signaling that validated clinical utility with payer readiness. This is significant and makes a significant impact in patient care going to a Category 1 code. Again, we want to make sure that coders are distinguishing among the standard CTA interpretation from AI-driven plaque analysis. Providers must document that this was an AI-derived metrics. PLA category growth. So PLA codes they're proprietary or FDA-cleared tests performed by a single lab or manufacturer, and more than a quarter of the new CPT codes in 2026 are PLA codes, reflecting rapid growth in genomic medicine, precision oncology, and infectious disease diagnostics, and AI-enabled panels. So we're seeing this significant growth here, and that CPT is supporting this growth. Coders, again, must match the exact essay to the correct PLA code, and the providers need to document the precise test that was performed in order to make sure that there's alignment with those CPT codes. So here's some examples of some of the PLA codes that have been added. These examples highlight how quickly diagnostic testing and technologies have been evolving. Coverage can vary widely, though, by payer and depends on the clinical evidence, FDA status, and guideline adoption. Again, we want to make sure that coders are aligning the test that was performed with the actual PLA codes, and providers need to make sure that they're documenting clearly exactly which test was ordered and performed in order to make sure that we're using the correct code for these services. Radiology overhaul. So 2026 includes one of the most significant radiology restructures in more than a decade, driven by increased procedural complexity and technology-enhanced imaging. Again, there's significant improvement and addition of new codes, including new Category 1 codes and major updates to what is required by documentation. Again, we want to make sure that coders are trained on these new codes and understand the documentation required. And we want to make sure also that providers are trained, that they must document the procedural complexity and understand exactly which services are being performed. So we're lining CPT codes with the documentation and the services performed. Vascular coding update. So we had a significant number of changes here. Legacy lower extremity revascularization codes have been completely deleted effective January 1st. Those were anatomy-based codes, and they no longer reflect the modern multi-level interventions. So obviously, we're going to stop using those. The new codes change to entirely territory-based codes and complexity-based model. So the old codes, they were too anatomy-based. There was unlimited availability to report multiple lesions or multiple territories. So this caused inconsistent coding. So these changes are significant and help us align with more modern coding. So the new codes, so the vascular coding update, they now align with modern PAD workflows, with limb preservation programs and hybrid intervention. So again, coders must understand the territory-based logic, and providers must clearly document and clearly describe the procedural approach to make sure that we are aligning with the correct codes. Again, I think compliance teams are going to want to provide audits in this area and make sure that the correct codes are being utilized and that the documentation supports those codes. So again, each code here is going to account for territory, intervention type, lesion complexity, and whether the lesion is initial or additional. This is going to apply more coronary style logic for the coders. And again, the providers must support coding with detailed operative notes to make sure that the documentation is complete and that we're aligning with the new CPT codes that provide more territory and intervention type. And we're going to be able to support the complex services that are being provided. Okay, moving on to CTA updates. So the new CTA codes reflect expanded use in stroke pathways and advanced vascular imaging. Again, this is going to use high resolution CTA, and it provides for a better stroke triage and, again, additional AI-assisted vascular analysis. So again, we want to make sure that the coders are selecting the correct CTA code and providers are documenting the clinical indication clearly to make sure that the medical necessity of these services is supported. So some of the specifics on the CTA update is the head and neck imaging has been modernized to reflect whole neck coverage, tandem occlusions, and pre-intervention mapping. Again, making sure that we're confirming the territory accuracy and providers must document the rationale for using these codes. CT perfusion or CTP. So the CT perfusion descriptors were updated to support modern stroke triage and tumor evaluation. CTP is separately billable only when medically necessary, when it's distinct and clearly documented. So again, we're going to be looking at the provider's documentation to make sure that intent has been documented, and that way the medical necessity is supported on these codes. And again, the compliance team should monitor the AI-driven perfusion use. Procedural imaging updates. The new 2026 CPT codes for procedural imaging have updated the bundling rules, and they've changed across interventional services. So again, we want to make sure that we're reassessing the guidance on reporting these codes, and providers must clearly describe the image guidance being used. I know that this is, not always documented clearly, and we want to make sure that in order to support these changes, and have clear documentation. We must have clear documentation that supports the use of these the codes. So the vascular interventions, again, tumor ablation procedures as well. Irreversible electroporation, IRE, sorry. IRE is now has category 1 codes, which replaced the unlisted reporting. That's great news. And documentation must include lesion details, the imaging modality used, the electrode placement, and pre and post ablation imaging. So the coders again must transition and understand the use of these codes, these new category 1 codes, as opposed to using the unlisted codes that they were previously using. And providers must document thoroughly so that these codes are supported. We've had a full audiology overhaul. The legacy codes were deleted. So codes 92590 to 92595 have been deleted. The reason for this is the outdated descriptors. They really don't describe the services that are being performed and the way that providers are performing them. So not enough granularity to support the modern devices that are being prescribed for patients and being used. So there's no longer reflect time-based services. So now we have an entire new set of codes with 12 new codes being added to align with how audiology practices are currently working. So the new audiology codes reflect the full care continuum. They start with candidacy through post-fitting verification. And so they have, again, 12 new codes in these categories. So candidacy evaluation, device selection, fitting procedures, post-fitting behavioral verification and follow-up, and then the electroacoustic verification. So I guess, again, coders must be educated on this new component-based logic, and providers must document each phase distinctly. Again, making sure that time and verification requirements are met. So I have spoken quite quickly today, but that's okay. Preparation is definitely going to be the differentiator for 2026. Coders need targeted education, QA, providers need updated documentation templates, and compliance teams really need proactive readiness to reduce audit exposure. Um, So, closing summary, obviously 2026 is a complete reform year, and it reflects how care is delivered today. Organizations should be preparing early to protect revenue, reduce denials, and we need to make sure that as we're implementing these new updated services, that the codes align, that your documentation aligns with the CPT codes and the care modalities that we're seeing. So, again, thank you for joining today's session. For continued 2026 education and implementation support, please visit us at E4 Health. And we will be also adding another webinar to talk more about documentation requirements, talk a little bit more about auditing and what you can do to audit and begin supporting the new codes. So thank you.
Thanks, Julie. I'm just grabbing the link right now. I'm going to open up the chat in just a second here, and I'm going to drop um, the evaluation link in there. I will also put it in the Q&A. And since we have a little bit of time, if anybody has anything they want to put in the Q&A, as I do that, maybe Julie, we could keep an eye on that for a minute or two. I don't see anything in there at the moment, but yeah, well, it's good to be abbreviated. And as you mentioned, you are going to do a second session on this. And in that second session, which I will be sure to get the information about that to everybody on this line, what are the type of things that you might cover in something like that as I get this link up here? Oh, and I think you're on mute, Julie.
I'm so sorry. Thank you.
So in that second session, what would you expand on
Yes.
in that?
So we're gonna talk more about documentation requirements for each grouping of these CPT codes. We'll talk about all the new codes, talk more in depth about audits. So how to set up an audit, how to look at what documentation is required for each of the new codes. So we'll go through a little bit more depth to kind of dive into how to prepare.
Excellent. Okay, I am dropping the evaluation link in the chat. I'm also going to pop that over here into the Q&A. Yeah, and I think giving a little bit of time back during these busy holiday times isn't the worst thing in the world, Julie. I, for one, have not checked everything off of my holiday list that is to do. But
Neither have I, Mike.
Yeah, we're busy making sure we take care of the customers up until the last yeah, and during this busy season. But keep an eye on here. Maybe we'll give just another minute, and if not, maybe we'll close it out. I'm gonna make myself an eggnog and look to power through the rest of this afternoon. You know what I'll also do, and we are building out our calendar for the year. I want to thank everybody that's been joining so many of these education sessions that we've done. I'm going to drop in, if you want to check out more over the next couple of weeks, we are going to kick back up in the mid-January timeframe, but we are going to take a little bit of break from this education. But if you want to continue to extend your education, we've got a ton of free education courses in that IQ Center, which is a great resource from a diverse array of topics. I mean, I'm a little bit biased, but I think we have the best team of educators around. So be sure to peruse that, share that with your team. All free, something that we just love to do to support the community. Julie, with that said, not seeing anything in the Q&A, and you know why? Because you did such a great job explaining all these important updates to everybody. So I knew you would. With that, let's as we wrap up, as I mentioned, keep an eye out for registration details for our upcoming webinars, including part two of this CPT update, where we'll have lots of other information. You can be sure that we'll be sharing that through email and on our different platforms. Be sure to visit the IQ Education Center. I dropped the link in the chat right there for more CEU accredited courses and other on-demand content. And yes, I agree. Great presentation. Thank you all for joining us today. Special thank you to Julie for sharing your expertise with all of us and your time. And on behalf of E4 Health, have a happy, safe holiday season, and please enjoy the rest of your week. Thank you all for your time.
Thanks, Mike. Happy
Thank you.
holidays.